Why don't we get started? I expect people to kind of trickle in today. If your ride home or in was anything like mine, you traveled. The ride home yesterday was just, for me, terrible. I mean, there were buses blocking, spinning around, and trucks spinning their wheels, and cars who seemed like the drivers had never seen snow before, which was surprising since it's not really new to Connecticut. But we're all here, and our attendance will be well rewarded. So, in terms of upcoming schedule, you've probably figured out by now that next week is Thanksgiving, so we will not have Grand Rounds on Friday. The following week, which is the 30th of November, we're going to have a very special Grand Rounds. Andrew Solomon, who many of you know, is both a wonderful writer and advocate and director of the Penn Foundation. He is my special advisor on LGBTQ issues, and they've made a movie from his book called Far From the Tree, and on the 30th we're going to watch the movie, and then we're going to have a discussion in which a few of us and Andrew will participate to talk about the movie. His book Far From the Tree is really a wonderful book, and I recommend that, and his earlier book Noonday Demon, which is about depression, in which he talks a lot about his own experience dealing with depression. And Far From the Tree, which is, it's not a second book, but followed the Noonday Demon, is a story about what happens when children and parents are different. So, for example, parents who have autistic children, or parents who have deaf children, or deaf parents who have hearing children, transgender, transsexual children, things like that. And it's a really wonderful, thoughtful book, and I'm sure it's a wonderful movie. And he's he's an incredible person, and it'll be great to hear about that. On the following week, December 7th, we're going to have a special joint Grand Rounds with the Department of Internal Medicine. Unfortunately, I will not be able to be present for that because of a conflicting meeting. But it's about underrepresented minorities in medicine. And Department of Medicine, Department of Psychiatry co-sponsoring this. I think it'll be a really wonderful and lively discussion. I think it reflects the ongoing commitment of certainly our department, and I'm sure internal medicine and other departments, to do what we can to continue to work on the climate issues that we face here at Yale. And I think it'll be really good. Just like the town hall, I thought that we had recently was really both enlightening and very, very engaging. So without further ado, I'm going to introduce our introducer, as I usually do, which is Jerry Santacora, to introduce our speaker today, who's an old dear friend of mine, Madhukar Trivedi.
Thanks, John, and thanks everybody who struggled through the weather to get here. I'll keep this very short to give Madhukar time. I'm sure most of you have already heard about Dr. Trivedi. He's originally did early training in India, then did a repeat residency at Henry Ford Hospital in Michigan. And then we were all talking about one of us who move rarely, went to UT Southwest and has been there since. You can see his title. That'll take half our time reading it, but it holds many positions. But I think it really gets to the key point about Dr. Trivedi. When it comes to depression, I don't think there is anybody else who has had as much of an impact as he had on the research and the clinical delivery of depression, spanning early interventions, including moving towards collaborative care models, but also into treatment-resistant depression and even into the basic science research, helping us through identification of novel biomarkers and pathophysiologic mechanisms that give us new insights into drug development. And it's always a pleasure. Any meeting we're at together, Dr. Trivedi is really somebody who is able to think out of the box, think, what's really the key issue, and I think if there's anything that may be Dr. Trivedi's strongest suit is really being able to look at the data and say, this is what's important and this is really what we need to do about it. So I think today we're going to hear about EMBARK. I'm not sure if people have heard about that. Dr. Trivedi has been part of all the big little acronyms, like the Texas algorithm and the STAR-D study, and now EMBARK is really one of the big projects funded to try to understand how we can use biomarkers to help predict or lead development of novel treatments. So with that, I'd like to introduce Dr. Trivedi. Thanks.
Good morning. Thank you so very much, Jerry and John and all the friends here. It's a pleasure to be here. I am going to try to sort of give you a little bit of the prelude to what what took us to developing EMBARK, and some of the early findings from EMBARK are just coming out, so I'll show you. But more to come over the next several years. I think it was like STAR-D, the whole endeavor with EMBARK is going to be a big study of 300 patients with a lot of markers, and I'll go over that in just a minute. But I think we are at a point where we should begin to think about the following. Obviously, we are trying to understand the pathophysiology of a lot of our presentations. Obviously, it's very clear, and it should be clear to everyone, even in other fields of medicine, that our diseases are very heterogeneous, and therefore treatment responsivity is even more heterogeneous. And we have not really figured out how best to match patients with the right treatment. So therefore, we as a field are well known for being sort of trial and error. So if you've tried, I always joke about it, is that I am so very happy that there are only 5 SSRIs that are approved by the FDA, because if there were 6, people would use 6, one after the other. And so I think that is, so we have to start thinking about, are there blood and brain mechanisms that we can use to at least subgroup patients, and in the process figure out a better way to match patients with treatments. Otherwise, we are actually just blindly throwing treatments at patients, and patients know this. So our patients actually are aware that we are not actually clear about why we are going from one treatment to the other, and that is very depressing for a patient with depression, I can tell you. So we know all the numbers. This is not unlike a lot of other chronic medical diseases. This is a disease of the young. So half the people with depression who are going to have an episode are going to have their first episode before the age of 18. 75% of people actually will have their first episode before the age of 30. And so most people with the illness will live throughout a very long life with these symptoms. We decrease. The life expectancy for patients with depression is reduced by at least 10 to 12 years. So these are people whose lives are shortened not only from suicide, but suicide is indeed one of the most stark examples of why this happens. And unfortunately, ever so slightly, suicide rates are going up, and teen depression rates are also going up. And we actually don't really know why that is the case. In this whole setting, the unfortunate reality is that the outcomes for real patients with depression in the real community are actually horrible. So only half the people get diagnosed. And people ask you all the time, why is that? Why don't people go and ask their doctors to give them treatment for this? Imagine if somebody said that same thing for hypertension. We would only diagnose hypertension when there is a stroke. We are doing that with depression, and so half the people don't get diagnosed. Those who get diagnosed, half of them don't get treated. Bottom line is, only about 6% of people with depression in the United States achieve remission. This is in the short term. If you want to think about this as a real illness and it's a chronic long-term illness, then remission rates actually for the population as a whole are even lower. For example, this is in STAR-D. As Jerry mentioned, this is still, unfortunately, remains the largest trial ever done for depression. So that is both good news and bad news. The bad news is 20 years after the trial was done, nobody has actually done a larger trial. This wouldn't be tolerated in cardiovascular medicine or in cancers. They would actually start doing it because there are important questions that this idea raises. Nobody's tried to attempt it. One short story about this, just so you understand, even for people, for example, after the first treatment, second, third, fourth, and this included 20 or 17 antidepressant treatments, by the time somebody gets to fourth treatment step, remission rates are very low. But if these patients were identified early on, then you would have prevented these 9 months of waiting period and you could have started them there. The flip side of this is that patients who get into full remission here at the end of first treatment step, 40% of them develop a relapse in the following year. If you go to the fourth treatment step, about 75% of them get a relapse. So this is ill-sustained outcome if these people have not achieved remission early on. And so we don't yet know how best to do this. And so therefore, I think we should really be focusing on this, and that is what my center currently is focusing on, developing biomarkers that we can use to develop signatures for subtypes of patients. Obviously, there are biomarkers of various domains, so there will be biomarkers that look at diagnostic markers, predictive markers, mediators, long-term treatment response. I think we are much closer to where we can begin to give a very strong idea of moderators of treatment response, so that based on blood and brain-based markers, either fluid-based markers or imaging, EEG, etc., we are at a point where I think we can begin to figure out moderators of treatment response where you can safely say with some degree of certainty, 70-80% accuracy, we are beginning to see in various studies, where you can predict that somebody is better off with treatment A and treatment B is not good. I think that trying to just find predictive biomarkers is kind of a little bit of a lame outcome in my view, because all it does is it tells us who is likely to not do well. So this is what we have spent the last 20 years doing. Somebody who has an early life trauma, there's a lot, 200 papers every week on early life adversity. Early life trauma, poor early onset, poor recovery between episodes, chronic medical illness, substance use, suicide attempts, leads to poor outcome in the future. Now that is what 20 years of work has led to, but I can tell you if I asked my grandmother to define what is poor outcome depression, she would actually list those same things. We really have to find moderators if we want to do this. And the problem with diagnostic markers in our field, in my view, is we have not yet actually convinced our peers in our field and peers outside that the investment is needed, because if we really want to do diagnostic biomarkers for our illnesses, we're going to have to do larger studies. 200, 300 patient studies are not going to help us develop diagnostic biomarkers. Moderators-based biomarkers, I think 300-400 patient studies are likely to do, because we have recognized it's a heterogeneous disorder, and then we try to behave like it is homogeneous by doing 30 and 40 patient studies. I mean, the dichotomy about this in our field is just unbelievable. Is that on the one hand, everybody recognizes this is a very heterogeneous disorder, and every study is funded for 30, 40, 50, 100 patients. I can't, unless you are clairvoyant and figure out which subtype you're going to pull from that heterogeneous disorder and study it, I think we are making a mistake. So that's my 2 cents worth of trying to really appeal to our whole peer review process to really question how we are doing this. We are going to have to look through a fairly robust domains of biomarkers, because at the end of the day, we are still trying to understand the exact pathophysiology of presentations of our patients. And so therefore, I think we are stuck, unfortunately. But one of the aspects that we have to really be focusing on is not stop at discovery, which a lot of us have done, and I'll show you some of that. But I think that is a good example where discovery should immediately then lead us to helping figuring out qualification, verification, and validation of any of these biosignatures until we can, so that we can use them routinely in routine clinical practice. Unfortunately, clinical markers are not going to do the trick, and therefore we need to look at biological markers, and even there, it is very unlikely that one single biomarker is really going to actually explain variance in most patients. There are going to be subgroupings, and I'll show you some very exciting examples of those, but otherwise I think it's going to be an interaction across several domains that's really going to give us, so to speak, an index, very similar to what other chronic medical diseases have had to do. There are very few medical illnesses where one test actually gives you both diagnostic and moderator effects. So we also have to be thinking about bringing back basic mechanisms and psychopathology into the understanding and not just to blindly evaluate these. So for example, and I'll show you some of our data, inflammation and metabolic markers are really beginning to have a much better understanding. But even there, I think we are going to have to figure out, even with inflammation, what aspects of the inflammatory process, whether it is Th1 cells, Th2 process, which aspect is really affected for subgroups, so that you can then use treatments that match. Otherwise, we are failing there also. So as I mentioned, I think I would love to do these things, but I am more thinking that we are probably much better at finding treatment response-based moderators of treatment response, maybe mediators, although that work has not actually panned out. We did the mediators in EMBARK also, and I think finding the right sweet spot of when you see the initial physiological change is not yet very clear. But eventually, hopefully, we will be able to then identify these subgroups that can be matched with individual treatments, and I think that is the kind of work people are doing. So far, studies have really helped us understand that some of the markers where we have a much better idea is if you do task-based fMRI or probabilistic reward tasks that help you decipher reward circuit dysfunctions, and especially in those with anhedonia. There is now much better resolution from functional MRI studies, and we've published on that shows that you can actually match patients with treatments there. Emotion processing and regulation circuit, I'll show you some of that data from EMBARK. And emotion conflict regulation, if it is impaired, then and especially the higher impairment you can identify are much better off on an antidepressant medication versus placebo, and the effect sizes are actually quite robust. There has been a lot of work on inflammatory biomarkers, and I'll talk from our data, but I think there the problem has again been that it has been generally very non-specific, and I think that you're seeing some of the early anti-inflammatory treatments, especially biologics, not yet showing any efficacy. So that may be something we have to understand. There's some very interesting data from metabolic markers, especially sphingolipids and ceramides as mediators of worsening depression in people, especially who have elevated BMI or other metabolic syndrome indices. And then the gut microbiome animal data are very interesting. I don't think that there is yet any published human data with gut microbiome that can actually help us decipher this. Very little in terms of human data, although the animal data are very interesting. The human data, if you look at gut microbiome in depression, then there are more reviews on gut microbiome and depression in humans than humans who have been studied. So what our biggest task should not be to just find predictors of treatment response. Our biggest task should be that at the beginning of baseline, either based on some proteomic genomic signal or a circuit dysfunction, one should actually say that this patient is better off on this treatment and avoid this treatment. Until we get to that selection process, I think we are going to remain at the trial and error process, and we have to avoid that. This is from the iSpot data, which is a very large multi-center trial, about 1,000 patients, and you can see none of these markers actually, clinical markers, were able to actually segregate from 3 different treatments. So clinical markers are not doing well. There have been attempts with genetic markers, and so we have heard a lot about pharmacokinetic markers, as you know, from GeneSight and a number of commercial companies that use their chips to try to give report cards on antidepressant treatments. They are valid, but I think that that is just pharmacokinetic. Until we get to pharmacodynamic or distribution markers, we are not really enhancing. I mean, what you find is that somebody is a slow metabolizer or a fast metabolizer. I don't even know if that means you absolutely are contraindicating that antidepressant or you just use it with care. If it is a pharmacodynamic or distribution marker, then I think that we would be able to enhance treatment selection. There's some interesting data from the chaperone protein for FKPP5 with Holzbauer's data as well as Elizabeth Binder's. That may be something that is worthwhile to use. The other 5-HT2A receptor and the transporters gene effects are very small, so they have been studied, but the variance that it accounts for has been very small. The ABCB1 gene actually is very intriguing, and I'll show you the results. So bottom line is these attempts through STAR-D and through GenDep have not really given us enough indication that we can use it. There are replicated findings like with the serotonin receptor gene or the transporter gene, but the amount of variance that any of these account for are very small, so I'm not sure you can go out and use it. There is an intriguing set of distribution markers like the ABCB1 gene. This is from a chronic depression trial we did, Schatzberg's group and our group, and looked at these 2 SNPs in the ABCB1 gene, and you can see that if those patients who are carriers of this allele have a significantly better remission rate than those who are not. We are now trying to follow this up with doing MR spectroscopy studies to argue, because if you use a PGP substrate drug with these SNPs, then there is theoretically you're actually increasing sequestration of the drug in the brain so that you're getting a higher brain level of the drug, and we are trying to prove that with MR spectroscopy. If that is true, then these carrier groups can be given PGP substrate drugs and you'll get a better remission rate. The problem, obviously, as you can see here, is that the proportion of patients who have these SNPs is very small. So it is a powerful marker, but for a small group of patients. And that is another way of looking at this, that we have not actually done that in a lot of these studies. So that is something we should think about. Let me move to a couple other studies, and the first one is the Coma Trial, because after STAR-D, everybody said that maybe you should use combinations to begin with and see if that produces a better outcome. And we found that combination of SSRI plus bupropion or venlafaxine plus mirtazapine does not lead to any better outcome either at the 12-week or the 7-month duration, so that they all have similar remission rates. Doesn't buy you more by starting people on combination. But as part of that study, we had collected plasma samples, and so I'm going to show you some of the data related to proteomics analysis from that. So we mainly looked at inflammatory markers. There's now very good evidence for all this, so I'm not going to belabor this. There are high rates of depression in patients treated with interferons. High CRP levels been associated with greater risk of hospitalization and suicide. And anti-inflammatory agents may improve depression in those with high inflammation. I want you to think about that. I think that, again, this idea that anti-inflammatory agents will be useful for everybody has been exaggerated, and I think we have to figure out who to give these treatments to. So we looked at three markers: C-reactive protein, IL-17, and PDGF. IL-17 in some ways is very interesting because IL-17 is only produced in the gut. So if there is elevated IL-17 levels, one must, we have to then evaluate further, but it is likely that there is gut permeability problems these patients have, and maybe their gut microbiome actually is affected. We have not, in at least COMED, we did not do it. We are now doing that in a subsequent study, and we'll find out if elevated IL-17 is associated with any specific gut microbiome changes. And then the PDGF were the three we looked at. I think there's ample evidence. This is from Paul Greengard's group, showing that at least bupropion, mirtazapine may have different effects on inflammation than SSRIs, and so that is really been tried with a study that from GenDep that Rudolph did, looking at CRP levels, and found that people at lower CRP levels, SSRIs were effective. At higher CRP levels, the tricyclic antidepressants were more effective than SSRIs. And the Emory group with Andy Miller have looked at CRP levels with a different cutoff. They look at more than 5 to mimic what happens in cardiovascular medicine, and did find, they did a infliximab study with patients who were treatment resistant and had no other inflammatory disease, and treated them with infliximab versus placebo, and found that the infliximab or Remicade is not more effective than placebo for patients with TRD. But only those patients who had CRP more than 5, they were the ones who got infliximab was superior statistically. Small sample, but it did indicate that in order for these treatments to work for patients with inflammation, they have to have inflammation. So we looked at these three, as I mentioned. So we looked at C-reactive protein for patients on either SSRI or bupropion, and we found, as you can see, that patients who were given SSRIs and had elevated C-reactive protein, they did not actually have a good outcome. On the other hand, patients who were given bupropion, the effect was actually much more robust and better outcome for bupropion. So suggesting that elevated C-reactive protein could be used as a discriminating variable to select patients' treatments. So this is unselected patient population between SSRI and bupropion, remission rates are 31%. If you matched patients with their CRP levels, so that if their CRP was less than 1 milligram per liter, and you gave them SSRI, and if it is more than 1 and you gave them bupropion, your remission rate can increase to 53%. So we are now proposing this as a prospectively done trial where we will do C-reactive protein at the point of care in clinical practice settings, and randomize and assign patients based on C-reactive protein levels, and see if we can actually replicate this finding to be able to validate this. So this is the kind of work that we need to be doing, and hopefully more of this will get done. So why look at IL-17? I think, as I mentioned, IL-17 is really an interesting marker to study. IL-17 leads to, in mice exhibit actually, elevated IL-17 in mice exhibits learned helplessness. You can transfuse Th17 cells to promote learned helplessness, and you can inhibit IL-17 that would mitigate this learned helplessness. You see the same with IL-17. You get no benefit or in fact worsening with elevated IL-17 levels, and you get much more robust positive effect with bupropion if there is an elevated IL-17. The venlafaxine mirtazapine effect is modest, so I don't know what to make of it, but it seems to be actually going in the opposite direction, so that elevated IL-17, if you give mirtazapine venlafaxine, then patients actually worsen on these antidepressants. More needs to be done with this arm. It was a small effect, but this effect is much larger, suggesting again, if the patient comes in and you do IL-17 level, doesn't make sense to give them an SSRI. Finally, PDGF we looked at in the same cohort and found, and just by the way, PDGF or prostaglandin or plasma-derived growth factor, it really changes the blood-brain barrier, and as a result, actually, it allows for infiltration of cells into the brain, and hopefully that potentially is the mechanism by which elevated PDGF may be actually leading to worsening of depression. We again found the same consistent pattern with PDGF and bupropion, but the interesting thing there was this was primarily driven by patients who had anhedonia. So not only elevated PDGF, but those with elevated PDGF and anhedonia was where the effect was coming from, but a very robust effect for positive effect for bupropion. You had elevated PDGF and you had anhedonia. A very small, different approach to this with exercise as a treatment for depression. We did a study looking at high dose versus low dose exercise several years back, and it showed that the high dose exercise works better than low dose. All of you are wondering what high dose is. I can tell you at some other point, but it's not a stroll in the park. But the big issue was we looked at TNF-alpha in that population, and this is very exciting. And so what we did was we looked at TNF-alpha for patients before they started the exercise treatment. And you find that those patients who had elevated TNF-alpha were the ones actually who did better on exercise. That those who did not have elevated TNF-alpha did not do well on exercise. And this is an example of where this precision starts beginning to be helpful, because exercise is an anti-inflammatory, and you have to have some degree of inflammation for exercise to work, is what this shows. And I think that kind of matching has been missing in our field, and I think we need to be thinking about this as we start developing precision models for how to select this. Now I'm going to talk a little about the EMBARK findings and then stop. How am I doing on time? Okay. So EMBARK was a large multi-center trial which included Columbia, MGH, Stanford, Michigan, Pittsburgh. I'm sure I'm going to miss somebody. But 300 patient study where we did extensive clinical markers, neuroimaging markers using resting state connectivity. We did emotion processing task, reward processing task, and we repeated ASL, DTI, cortical thickness, and we repeated all this at week 1. We did EEG, we did theta activity as well as loudness-based evoked potential. We did cognitive and behavioral phenotyping, and we collected blood samples, and these are the reports that are just beginning to come out now. Give you an idea, there were basically, it was 296 patients were randomized to either sertraline or placebo, and we looked at the efficacy, looked at these biomarkers to predict treatment outcome by treatment and across treatments. We have published about the basic baseline phenotyping of this. So we found 3 endophenotypes with just EEG and some of the other behavioral tasks that looked at gamma current density and neuroticism, gamma current density and reward learning, and gamma current density and flanker interference, all 3 showing 3 different patterns of EEG activity, and their treatment response is different. So these endophenotypes, they reflect basically potentially 3 underlying dysfunctions, and the outcome differences, I think, help you then decide again treatment selection for these patients. The example of what we as a field need to be doing is something that Helen Mayberg's data is used. This is from her biomarker look at using whole brain PET and using comparison of cognitive behavior therapy versus escitalopram for different circuits, including the anterior insula, inferior temporal, amygdala, precuneus, and premotor cortex, showing different patterns for those patients at baseline who do better on cognitive behavior therapy versus SSRI. And she's now randomizing patients based on this circuit dysfunction to select patients' treatments, like I was saying about bupropion and SSRI, and in showing the efficacy for how best to decide which patient should get either psychotherapy or medication. So in EMBARK, we looked at additionally ASL and the moderators of treatment outcome between sertraline and placebo are quite extensive. These are regional cerebral blood flow regions. But if you then develop a composite marker of blood flow changes in patients with who were given sertraline versus placebo, then the composite effect is about 0.557 effect size, so that it tells you that the blood flow changes seen in patients who are getting sertraline before treatment, if they are in this pattern, then their chances of getting better on sertraline versus placebo are significantly higher. The issue is that right now we are not assigning patients based on their blood flow. We are assigning them based on random assignment between drug and placebo. So if you assign them and they receive the drug, that is, they had received the drug, then the effect is much better than if you assign them, but they then received a placebo, for example. So this mismatch on what patients get and what they should be getting is really what we are beginning to identify. One of the other findings in regional connectivity we are finding with EMBARK is there has been clear evidence in the past showing at least changes in default mode network and salience networks in people with depression who then do better on an antidepressant versus a comparison. No drug placebo study has ever been done to look at these moderators of treatment outcomes. So that is a major problem with the field. But those comparison studies, either with medication versus psychotherapy, et cetera, have found hyperactivity in the default mode network and the salience network. What we find in our study, which is more important, is it is not just the increase in connectivity in the default mode network and salience network. It is the inter-network traffic or connectivity increase that is really the major marker for drug preference, as in the sertraline preference over placebo. So just that default mode network connectivity is increased doesn't seem to be enough of an indicator of better outcome for drug. But if there is increased connectivity across these networks, then the effect size is actually 0.6 for sertraline versus placebo. So I think there is increasing evidence that we can use these markers for subgrouping patients and then deciding one versus the other treatment. It is now time to actually start doing validation studies, in my view. The only other next step I think that we have not yet so our bioinformatics colleagues, we are working with our bioinformatics department to try to develop a machine learning multimodal index from various markers that we have studied so far to develop a biosignature. And that is going to require us to collect these samples across larger samples in the future. And one of the other final points I'll make is we have been behaving for depression, at least, and for across many disorders, but for depression, as if this is some kind of an acute, short-lasting illness. It is actually a chronic, relapsing, recurring illness, and there is no real data for long-term biomarkers about how to expect long-term outcomes at the end of 2 years, 5 years, or 10 years. And so at least at our center, we have launched 2 large cohorts, those with people with depression, bipolar disorder, and those at risk, that is offsprings of these people, and we're getting about 4,000, 2,000 each, and getting 3 times a year serial biomarkers to see what can be used to predict long-term outcome. I'm going to stop here for questions. Thank you.